Hi, I'm Walt Fritz. I'm the director of the Foundations in Myofascial Release Seminars, and I'm here at Oakworks today to shoot a few videos on myofascial release evaluation. To me, the evaluation is one of the most important aspects of treatment because without a thorough evaluation, you really don't have a firm foundation on where to start, on what to look for. We tend to end up treating symptoms, treating where a person feels the pain, versus trying to track back a little bit and find out why they're having the pain and where it might be coming from. So during my evaluation session, I like to get a nice long view of my patient standing across the room. I want to be able to see them from all different angles. And prior to coming, my patients already are aware that I want them to come in clothes where I can actually see their landmarks. If they're coming in with jeans, etc., you're just not going to be able to see and feel what you need. Now, if you can imagine the imaginary plumb line coming down from the ceiling, dropping through the center of her head, down the middle of her torso, and landing down between the two malleoli, I want you to just soften your focus. Try and see beyond her. Don't look at the details. Get the bigger picture. And I think certain things will become pretty clear. You'll notice that her right knee seems to be bearing more of the weight than the left. Her right hip appears elevated. The right shoulder's slightly low. Getting her to relax a little bit. Let's see where her head settles. Head is pretty well aligned there. You also notice that you're looking at the back of her hands. There's a fair amount of internal rotation at both of her shoulders, certainly indicating some tightness across the front of the chest, front of the shoulders. Now, if you could, turn 90 degrees to your left, please. Soften, take a breath. Again, we're going to drop that plumb line through the center of her ear. It should drop down through the shoulder, the hip, the ankle. And if you'll notice, she's pitched forward just a little bit. Small amount of anterior rotation that we're going to measure in just a moment. When you move up to the shoulders, you can see at least the right shoulder is drawn forward quite a bit. And the head is just a tad forward. And you can turn and face away from us, please. And I think from the back, we're basically reinforcing what we saw from the front. The right hip is slightly high. Right shoulder looks a little low. If you take a look at the space between her torso and her arms, you can see there's an asymmetry there. We can see a little bit more wall on the right side than the left. Scapulas both appear pretty well drawn apart. And head is in fairly good midline. Okay. Next, I want to move in for some basic orthopedic assessment. We want to take a look at some of the bony landmarks of the pelvis to determine the symmetry of the pelvis as well as how far forward the pelvis is tipped. To do that, you need a basic understanding of where the posterior superior iliac spines are, the PSISs, as well as the ASISs around front. So I'm going to, is it okay if I lift this up? Mm-hmm. Okay. And we're going to locate the PSISs. Now, on many people, there's some very slight dimples right here, which coincide with the approximate position of the sacroiliac joints at the PSISs. Other people don't have the dimples, but if you place your hands on the crests of the pelvis, the thumbs tend to drop pretty much right into place. And remember, on a female, the sacrum is slightly wider than on a male, so if you're evaluating a male patient, you're going to be looking a little bit more to midline. But in Molly's case, she's got the clearly defined dimples, which give me a landmark on where to start. I press in just slightly until I find those bony landmarks. And it's pretty obvious that she has a high PSIS on the right. Now, Molly, I'm going to have you turn back towards your left. I'm going to keep that position with one of my fingers. The other hand is going to palpate for the ASIS, the anterior superior iliac spine. Those 2 points form an angle. Now, typically, I would bring a goniometer, an angle measurement tool with me, but I don't have one here today. But I think we can eyeball this angle at about probably 15 to 20 degrees, somewhere in there. You can relax there. The statistical norms for males in terms of an anterior pelvic tilt are 0 to 5 degrees. For females, it's 10 to 15 degrees. So Molly's just at the far end of the range of normal, at least what I can eyeball here, for a normal amount of anterior rotation. All right? Now, if you'll turn and face me, We're going to repeat the same thing that we did in the back with the front. I'm going to come and find the ASISs. And what I like to do is, instead of perching right on top of either the ASIS or PSIS, I like to come under and draw up until the bony landmark stops me. I find it's a lot more accurate. And there are, where are we here? Okay. There I think you can see my right thumb on her left side looks like it's lower. So with the information that we gathered in standing, we're now going to move into a few seated evaluations. And the first one, we're going to do the Thomas test, which checks for hip flexor tightness. So Molly, if you could just scoot forward a bit. You want her fairly close to the edge of the table when they lay down. And in this position, she's going to bring one knee all the way up to her chest. Now, what I typically do is support the opposite leg. So your patient get that leg all the way up. If they're having issues with pinching in the groin, only have them bring it up to the point of comfort. Now, what you want to do is let the dependent leg drop. If the hip flexor, the psoas and the iliacus on this side, on her right side, are full length, this leg should be parallel to the floor. And I think it's pretty close to parallel. So that would be counted as a normal Thomas test on the right. Next, we're going to move into another seated assessment. And for this one, we are going to just check her trunk rotation. Now, I'm going to ask you, Molly, to let me do all the work here. And no matter what I do, it should always be within your range of acceptance and tolerance. If anything is too much or not right, tell me. Okay. So I'm looking for how far I can rotate her torso, not to the end of her full range, but to first barrier. Where do you begin to feel the first layer of resistance? And if I was standing on top of the table looking down, we'd probably have 60 degrees of rotation to the right. Now, do you have any pain when I do that?
I do in my lower back.
In your low back?
On the right.
On the right, okay. So now we're going to compare that to what we might find when we go in this direction. And it looks like we've got quite a bit more range to the left, probably at least 70 degrees. Does that bother you at all?
Not really.
So no pain to the right with better range of motion. She had about 60 and obviously some tightness and a little bit of resistance with pain. Mm-hmm. Where I go next is, I'm actually going to lower this table. We're using the Oakworks ProLux convertible, which allows you to use your own massage table on the power lift base, which is a great option. I'm sold on these power tables. And what I'm going to do is just gently put a knee in her back. If my knee feels too bony to her back, I could certainly pat it with a towel or a pillow. Then I'm just going to both push in lightly with my knee and pull back on her shoulders. I'm assessing for a number of different things here. I'm trying to get an idea how much tightness she has here in the front of her shoulders, in through the pecs, in through the chest wall and anterior rib cage. I'm also, with my knee, assessing how much thoracic spine and thoracic rib extension she has. And it feels like her lower thoracics, do you feel that spot there, Molly? Mm-hmm. Yeah. Her upper and mid-thoracics had some nice extension, but she's got a spot down around T10 which just doesn't want to extend backward. And here, shoulders, I can feel that tightness that we saw in the standing assessment across the front of her shoulders that are drawing everything forward. And we also saw in the, when we looked at her back in standing how widespread the scapula were, which makes perfect sense. All of this anterior tightness causes the scapulas to wing out, and this might be the type of patient profile where the person has a lot of spasm or pain back here in the rhomboids, back here in the scapular region. All right?